So, in today's episode, we're going to discuss an approach to delirium, or an acute confusional state. And why I feel is one of the most important topics that I've discussed on this podcast is that it's not limited to just neurology. It's a common finding in all hospital wards, whether you're medical, whether you're surgical. You'll often find patients that are acutely confused. And whether you consult neurology, whether you consult general medicine, I feel like every doctor should have an approach to how they work up these patients. If there's one takeaway from this episode, it's that delirium is a symptom. It's not a diagnosis. So we always need to look for what's the underlying causes and treat it accordingly. So let's start off with what we mean by delirium. So often we refer to it as an acute confusional state, but specifically it's an acutely disturbed state of mind that's characterized by restlessness, impaired attention, incoherence, reduced awareness of the environment, and possibly also presenting with hallucinations. One of the characteristics is that there's a fluctuating cause. So there's often periods of or intervals of lucidness. So the patient is actually completely fine and they wax and wane with these periods of delirium or acute confusional states. This is important to differentiate because in a patient that say has a dementia, that's a slowly progressive insidious onset, that shouldn't wax and wane significantly. The patient shouldn't be lucid at times, and that's a slowly progressive disorder. So when we think of the symptoms of delirium, patients can be hyperactive, they can be hypoactive, or they can have a mixed presentation. So the hyperactive delirium, these are patients that present with positive symptoms or increased psychomotor activity. So they may appear to be agitated, they may be disoriented, emotional ability, they may be non-cooperative, they could be delusional, and they could even experience hallucinations. Whereas the hyperactive patients present with more negative symptoms. These are basically subdued patients, quiet, they're quietly confused, they're a bit disorientated, they're inattentive, they're lethargic, and they may be apathetic. And often though you have a combination of these hyperactive and hypoactive symptoms. So when we have a patient that has these kind of symptoms, we need to think of maybe they're presenting with a delirium. So I think one of the reasons why I should give this podcast is to now come up with the causes of a delirium. And we can think about the predisposing risk factors, and then we can think about the precipitating risk factors. So the predisposing risk factors, these include patients of older age, underlying dementias, patients that have multiple medical comorbidities, history of alcohol use, sensory impairments, depression, or just a poor functional baseline. But importantly, what we have to work the patient up are for the precipitating factors. And if you're going to write something down, this is what you're going to write down. And it's a mnemonic that I remember actually learning when I was a student. And it's the DIMTOPS mnemonic. So DIMTOPS. So let's start off with D. So D is for drugs. And this is either intoxication, overdose, side effects of drugs such as anticholinergics, or even withdrawal. So D for drugs. I for infection. So either this could be an intracranial infection, such as like something localized like a meningitis or encephalitis that could be causing confusion. However, it could also be something just extracranial, like a generalized sepsis, UTI, and especially UTIs in elderly, or even pneumonia. It's an underlying infection that's causing delirium. Now we move on to the M for metabolic. And these include things like also electrolyte abnormalities, or hypo and hyponatremias, changes in calcium, hypoglycemia, metabolic acidosis, hepatic encephalopathies, uremic encephalopathies. So everything that is metabolic. Now we move on to the T. T can be for trauma, so primarily head injury. It could also be toxins. O for oxygenation, and this is primarily hypoxia, which can cause delirium. P for pain, so patients that are in significant pain, that could also be a cause. This should be a diagnosis of exclusion, and the last thing on the list, but P for psychiatric. So psychiatric issues are the diagnosis of exclusion, where you've worked up the patient, you find no medical causes, and maybe there's a psychiatric cause for, say, the hallucinations. And then S for things that are structural in the brain, or also seizures. And when we talk about seizures, we're talking about a post-ictal confusional state that can present in both clinical or subclinical seizures. So just a reminder, that's the mnemonic DIMTOPS. And essentially, with that list in mind, that essentially will guide your investigations. And investigations, or let's actually talk about history first. History, you might not get a proper coherent history from the patient because they're in a acute confusional state. And that's where collateral becomes important. So whether you're taking from the family who are at home with the patient, or you're taking from the nursing staff, or even other patients around. And then from an examination point of view, again, these patients are quite difficult to examine. So you're looking for obvious things on examination. When we look at the mental state of a patient, that's when we look at things like speech, language, orientation, attention, concentration, etc. And obvious things on examination, things like the hydration status, features of the oxygenation, any feature of system failure, signs of infection, and if possible, neuroexamination or whatever you can get. So investigations, that's important now, looking for causes as per our DIM-TOPS mnemonic. So basic things like vitals, assessing perfusion, saturation, features of infections or tachycardias, high temperatures, bedside tests like glucose, urine dipstick, ABGs and ECGs. On lab investigations, we're looking for inflammatory markers, metabolic markers, B12, folate. Imaging, we're looking for features of infections, a chest x-ray. You can look at things like abdominal x-rays, CT brain, and lab investigations. If we think there's a suspicion of an intracranial infection, we can consider things like lumbar punctures. But again, I would say that an unexplained acute confusional state may be a contraindication to our LP if we think that there's features of raised intracranial pressure, so maybe a scan before. And in terms of special investigations, we can do EEGs for these patients, and often that's looking for features of encephalopathy, which primarily manifests as slowing. Or again, if you want to exclude seizures of the cord, we're looking for intellectual activity. So how do we manage these patients? I said specifically delirium is a symptom, not a diagnosis. So we manage the underlying cause. Where there's dehydration, you hydrate them. If it's an infection, you'll treat the infection. If the patient's in pain, you treat the pain. Patients in liver failure, you manage that. So we treat the underlying cause as the mainstay of the treatment for delirium. However, there are other delirium-specific therapy that we can consider. Things like non-pharmacological things, we can look at the environment. So we reduce physical stimuli such as excessive noise. We allow for adequate lighting that's not too harsh. We introduce a sense of familiarity such as objects from home. We assist with orientation with aids such as a clock or a calendar. In terms of physical supports, we avoid a full bladder. Urine retention can be a precipitating cause or worsen delirium. In the same way, constipation can also worsen. So fecal impaction, we try to avoid that. We try and avoid physical restraints as far as possible, because often we know once you actually physically restrain a patient, it just escalates their level of restlessness. We encourage a normal sleep-wake cycle by having the lights on during the day and off at night. And if necessary, a patient should be using the usual eyeglasses, hearing aids, and dentures as well. And when it comes to social supports, we always encourage family members and familiar faces to visit and try and maintain a consistent nursing team as well. When it comes to pharmacological agents for patients with delirium, we can consider prescribing antipsychotic drugs which treat agitation and hallucinations. Drugs such as haloperidol can be used. Low-dose risperidone can also be used. However, obviously monitor for side effects and don't just treat symptomatically without looking for an underlying cause. Other sedatives like low-dose benzos can also maybe be used in the acute setting. So just to conclude, we said delirium as an acute confusional state is a symptom, not a diagnosis. It presents a patient with this confusional state with impaired attention, concentration, potential for hallucination, and often there's a waxing and waning course of periods of lucidity. Patients that are high risk are those include the in-hospital patients, the elderly, underlying medical issues. And when we look at the list of causes, we look at the mnemonic DIM-TOPS, DIMTOPS. If I quickly have to run through it, D for drugs, I for infection, M for metabolic, T for trauma and toxins, O for oxygenation, P for pain and psychiatric, S for structural and seizures. Our clinical assessment might be difficult, but we guide our investigations based on the causes, both bedside, lab, imaging and special investigations, and we treat accordingly the underlying cause. But delirium specific treatments will include things like non-pharmacological, like improving the setting, the environment, avoiding aggravating factors like a full bladder and constipation, and medical things or pharmacological will include low-dose antipsychotics like haloperidol, risperidone, or even possibly benzos in the appropriate setting. So that covers delirium. I hope that you take this with you. Come at these investigations when you see your patients, and that you don't always run to an immediate medicine or neurology consult. You can try and just manage these patients initially.